vagal nerve stimulation. So you kind of hit on that a little bit, but I think if we don't have any example of neuromodulation secondary to breathing, right? The fact that there are FDA approved treatments right now for migraine headaches, right? Seizures, right? Which is you have to manipulate the electrical activity in the brain in order to bring seizures down, right? FDA approval for vagal nerve stimulation for seizures and migraines. And like you said, depression. You brought that up too, right? If changing in breathing pattern is actually, activating the vagal nerve, I think that's like example number one as to, how breathing can actually neuromodulate your brain, your brain function.
In all fairness, when you look at the vagal nerve stimulation, they're stimulating the whole nerve.
Right.
And so they're not just stimulating afferents, which are signals going into the brain.
Right.
They're not just stimulating afferents from the lungs, they're afferents from all the viscera.
Okay.
And so we don't know what the effects, how to parcel those effects out. And I don't know the degree to which anyone has studied in humans just stimulating the pulmonary vagus. However, there is a patient population that I think should be looked at much more carefully. These are patients who had lung transplants.
Yeah.
Because they don't have a pulmonary vagus because it had to be cut. And then you can re-examine whether or not vagal nerve stimulation has the same effects. My prediction is that there'll be a marked difference in the absence of those pulmonary afferents, because I think those pulmonary afferents are driving a large part of the effects that you see from vagal nerve stimulation.
Yeah. Then what about the olfactory bulb?
What about it?
I love the idea of an olfactory bulb, right? Because it's like this connection straight from a stimulatory source straight under the ventral prefrontal cortex, like right into the limbic system.
Yeah.
What do you think about that? I mean, you seem to think that, and then that plays into nasal versus mouth breathing.
This is all interesting. I just want to make sure I answer it in ways that make sense. Clearly, under normal conditions, all nasal signals going to the brain are respiratory modulated. And the degree to which the signals are they're originating in the olfactory mucosa, going into the olfactory bulb, and the olfactory bulb not only is receiving respiratory input because of the oscillations of air in the nasal passages, but also receives an input from the central respiratory system. And so the signals that get passed on to the brain are very highly modulated. If you block the nasal receptors, people still can respond to changes in breathing. So sometimes I think it's misrepresented that all of the breathing-related changes are nasal. So you have people with anosmia, although the data seems to suggest it's not the odor receptors, but it's the pressure receptors in the nasal passages that are really transmitting the key signal. Okay. And I don't know how in anosmics, how that signal is affected.
Yeah.
But if you also have people breathing through trach tubes, so they have no respiratory modulation of their their olfactory signals, and they still can be very responsive to breathing-related things. Yeah. So I think that there's definitely a powerful nasal olfactory signal. In fact, I think there's a component of aromatherapy, which gets dismissed as being sort of too woo-woo, as driving a respiratory modulated signal that may or may not be directly correlated to the odor, but it's the respiratory modulation that, in fact, is really carrying the key information.
So you're saying a certain kind of odor that would translate a certain stimulus through the olfactory bulb might be different than a certain kind of odor that maybe isn't as pungent, is more bland, that would transmit a decreased stimuli through the prefrontal cortex and into the limbic system? Or are all odors the same?
Well, clearly all odors are not the same.
Right.
Okay,
But I'm saying from a stimulatory standpoint and what that would do for from a neuromodulation.
So you could look at it
perspective.
two extremes. You could say, okay, it's only the odor, and so we could eliminate the respiratory modulations. You just blow the odor across the nasal mucosa and see what the response is.
Right.
Now, certainly you can detect the smell of something without having it be respiratory modulated. The question is, what is the effect on behavior, and is it the same if it just gets blown across constantly, or it has to be carried on the respiratory modulation? I think it's, I mean, I don't want it to appear as if I have an axe to grind that everything has to be respiratory modulated, but it's a natural component of it that needs to be considered when you're trying to understand how these signals are being used by the brain for whatever the brain uses it for.
Yeah, got it. Is there a certain kind of breathing pattern that you think works better to target some of these neuromodulatory functions than others?
Well, if you look at breathing practice, there's a incredible range of breathing practices that seem to be effective. There is, box breathing, which is very simple, and it's what I recommend to people who want to try and experiment with whether a breathing practice can have an effect on their emotional state.
Right.
And box breathing is just typically 5-second inhale, 5-second breath hold, 5-second exhale, 5-second breath hold. So it's 20 seconds to go around. There's pranayama, which is just a somewhat different time in each domain. There's tumo. There is, it's just all, it's just all over the place. There's a breathing practice I'm quite interested in. I have to be candid. I'm not really an expert on this.
I'm wondering in terms of, these breathing patterns and the potential neuromodulation. I know we've gone through a lot of it now, but do you think it's more gas driven or the neuromodulation that occurs, is it more CO2 driven and the alterations in the actual blood gas, or is it something that's oscillatory potentially, that oscillatory modulation that you were talking about earlier? Or do you think it's both?
It's all of the above.
It's everything.
There's I think we have a review coming out, an annual review of neuroscience in the next couple of months, and we have a figure in there, and I think we say there are at least 7 different pathways that could be in effect.
Yeah.
We talked about olfaction. We talked about directly from the brainstem respiratory oscillator. We talked about coming down from volition, because if the volitional command is to change breathing, it can send a collateral signal out, and that can have an effect.
Right.
Blood gases themselves can have an effect. So Alicia Moret has done some really interesting work where she has patients who have clinical levels of anxiety, and when she measures their CO2 levels are low. In other words, they're hyperventilating, they're blowing off too much CO2,
right.
And she trains them to bring their CO2 levels back to normal, and that has a positive effect on their anxiety.
Right.
Okay, and that seems to be due to changes in their CO2 levels.
Right. Right.
An experiment that probably would be useful to do is to take these patients, instead of changing their way in which they're physically breathing, if they're a little bit hypocapnic, low levels of CO2, just give them a little CO2 to breathe,
right.
And see if that has the same effect. In other words, is it the breathing itself,
or the actual gas?
Is the actual gas?
Right.
So I think what's happening is that the phenomenology is well established. It goes back thousands of years. And I think that the neuroscientists and physiologists and physicians like yourself are trying to dig a little bit deeper into trying to understand the mechanisms. One, purely out of curiosity, but 2, that one might be able to exploit that for clinical benefit. In other words, certain breathing patterns might be better for certain types of disorders.
Right.
And if we know the mechanisms, we might, you might send someone home with an 8% oxygen tank and just say, breathe through this for 15 minutes. Or, you say, okay, I want you to hyperventilate for 1 minute and then hold your breath for as long as you can.
Yeah.
And they're very different protocols, and yet they may be optimized for different aspects. And these could be studied phenomenologically, but I'm one who wants to know the basic mechanisms and build up from the basic mechanisms.
Right. Yeah. Well, Dr. Feldman, thank you so much for joining me. I really, really appreciate it. So much awesome insight. And I think that we have a lot more to talk about, and I would love for you to be able to come back sometime if that's all right.
I think I would be delighted. There are lots of subjects that we can talk about that hopefully are interest to you and your audience.
Yeah.
And I would be privileged to come back.
I think we just scratched the surface.
Yeah.
But hopefully we'll have you back and we can dig deeper.
That sounds great. Thanks very much for having me.
Yep. Thank you, everyone, for joining us for another episode of the UCLA BrainSPORT Podcast. Dr. Jack Feldman. My name's Adel, sports neurologist at the UCLA BrainSPORT program. Thank you very much. Please stay safe. Be well. Bye-bye.